First speaker is a very eminent ophthalmologist from the armed forces, Brigadier V.K. Baranwal. He has got loads of experience in doing cataract surgeries. He's done multiple. He has been at various centers. He's been head of the department at Base Hospital, and his immense administrative load. He has been director of Sitapur Eye Hospital. So, notwithstanding that, he's going to speak on superior or temporal incision in cataract surgery, a case-based approach. Brigadier V.K. Baranwal, sir.
First of all, I must thank Brigadier Sanjay Mishra for giving me this opportunity to present the topic given to me in front of you. The topic is superior versus temporal phaco-incision. I have no financial disclosures. The importance of wound construction in cataract surgery is well depicted by the slogan, "Well begun is half done," by Aristotle. There's some problem in the... Because the phaco wound construction lays down the foundation for subsequent steps of the phaco surgery. It influences the fluid balance in the anterior segment. Then it has an immediate important role in the post-operative period when the wound is unstable. It helps to prevent post-operative infections. It ensures smooth and faster recovery. And last but not the least, it is a refractive tool for the pre-existing astigmatism. Few things about the astigmatism. Just to recapitulate, vertical meridian is something which is vertically, that is 90 degrees plus minus 20 degrees. Then the horizontal meridian is horizontally in the horizontal axis, that is 182 plus minus 20 degrees. It is and the rule is vertical with the rule astigmatism, which means the vertical meridian is 0.25 diopters, normally steeper than the horizontal meridian. This is supposed to be due to the pressure of the eyelids on the eyeball, and secondly, the vertical diameter of the cornea is about 1 millimeter shorter than the horizontal one. Then there are two main types of astigmatism with the rule astigmatism, in which the steeper meridian is in the vertical or the 90-degree meridian. This is much more common in young and myopes, whereas against the rule astigmatism, where the steeper curve or axis is along the 180-degree. This is more common in the elderly. The exact cause is actually not known, but it is supposed to be due to change in the pressure of the eyelids over a period of time as the age advances, and change in the stromal collagen fibers, which cause a shift from with the rule to the against the rule astigmatism. Then what are the important factors which influence astigmatism? First is the location. We'll discuss it out in the subsequent slides. Then second is size of the incision. It is estimated that 1.8 to 2.8 millimeter incision, phaco incision, induces relatively small surgically induced astigmatism. However, further reduction in this size has only limited benefit. Similarly, the incision, phaco incision length, it is estimated that shorter tunnel less than 1.75 millimeter causes very minimal surgically induced astigmatism. Then distance from the center of the cornea, as you go towards the periphery, the more peripheral incision causes less astigmatism. And another factor is multiplanar phaco incisions are better compared to uni and biplanar incisions as far as the astigmatism is concerned. A study by Archana Sunil Ekos et al., published in Clinical Ophthalmology in 2018, has suggested that temporal clear corneal incision induces less surgically induced astigmatism as compared to the superior incisions. The landmark study as far as astigmatism because of the phaco-incision is concerned is by Jaime Tedzor and Juan Murabe, published in way back in May 2005. This is the the criteria mentioned in this study are being followed worldwide even now. We will be discussing it in the subsequent slides. As far as the temporal corneal incisions are concerned, as we have discussed it out, it induces lower surgically induced astigmatism because incision is located at a more distance compared to from the central visual axis as compared to the superior incision. Also, it is better especially in cases where you have a prominent eyebrow and deep set eye, and it reduces existing against the rule astigmatism. Then the recommendations for temporal incisions are pre-existing with the rule astigmatism of less than 1.5 diopters, or pre-existing astigmatism of less than 0.75 diopters, or negligible pre-existing astigmatism. Then coming to the superior corneal incisions, the advantages are, the main advantage is that the incision is protected under the upper eyelid, so chances of infection are less. However, it induces more corneal flattening and surgically induced astigmatism, and it is difficult in prominent eyebrows and deep set eyes because the movement of the probe becomes difficult. So it is recommended for with the rule astigmatism of more than 1.5 diopters. Then few considerations beyond astigmatism. A study by Hamid Gare et al., published in Journal of Ophthalmic and Vision Research, has suggested that superotemporal incisions, they cause less corneal endothelial loss, cell loss. However, the difference is not much significant. Another study by Mohammad Anbar Hatem Amar, published in BMC Journal of Ophthalmology, suggested that whether it is you do a temporal incision, superior, superotemporal, it does not affect the IOP, bleb morphology or function after 1 year follow-up. A study by Snehal Bhaskar, published in Med Pulse in 2014, has it suggests that incision location, whether it is superior, temporal, superotemporal, has no bearing on the final best visual acuity in the long run. As far as deep set eyes and prominent eyebrows are concerned, the main challenges, as you all know, are difficult probe angulation, fluid pooling, and reduced visibility while operating. In these cases, temporal approach is better. And in cases of pre-existing corneal opacity, the site selection depends on the location of the corneal opacity and where maximum clear cornea is available. Aim is to orient the phaco probe so that tip is visible in the pupillary area, the clear area, and phaco is carried out in opacity-free area. As far as pre-existing overhanging trabeculectomy bleb is concerned, as you can see, the temporal approach is much easier and better. Another concern is there is something called as negative photopsias. This is supposed to be due to the edema at the incision site, especially seen in the temporal corneal incisions. However, luckily, it disappears when the edema at the incision site disappears. Usually takes about a week, so not of much problem or significance in the long run. As far as whether one has to do a superior phaco-incision, temporal, superotemporal, actually one should be position the phaco machine, microscope, and the chair and the trolley in such a way that one can manipulate or whether to do from the superior uh, part or the temporal incision, because you have to minimize the astigmatism. So for that, the surgeon also requires a positive mindset, practice, and comfort. The steps to decrease the pre-existing astigmatism, the most important is incision should be given on the steeper axis, and if astigmatism is up to 1 diopters, incision extension of incision by 4 millimeters or paired incision on the opposite axis, both the superior and the inferior also at the same axis, can correct astigmatism up to 1 diopters. And if you give more peripheral incisions, it causes less astigmatism, and if astigmatism is more, then you have to use the toric IOLs. The take-home message, the incision size or choice of the incision actually depends on the surgeon's preference based on his comfort, mindset, familiarity, equipments, and the OT size. Suppose the size of the OT is very small, you don't have place to maneuver the OT trolley or the microscope or the phaco machine or the operating chair, you don't have much choice. Second is the patient anatomy, that is prominent eyebrows, deep set eyes. For this, the temporal incision is better. Then pre-existing astigmatism, pre-existing ocular disease like pterygium, corneal opacity, pannus, and previous ocular surgeries or trauma. But for a general purpose and at a high volume centers, simplest is a clear corneal phaco incision along the steeper meridian. This is the easiest and the best one can do. Thank you so much for the
Thank you, sir. We'll take the question at the end of the presentation. Thank you so much, sir. I would like to add just one more point, that just don't blindly follow that you have to do a temporal or a superior incision. You have to practice in both settings, that is temporal as well as superior. You should be expert so that you're not uncomfortable if you are given a choice of doing in any of these positions. And you should make it a habit to look at your IOL power sheet. Very, very important. Just don't go blindly by what power is required. You see which is the steep axis and take the incision on the steep axis.